May not cover unemployed or informal sector workers unless government subsidies are provided. Delta State have taken care of that. Formal sector have been taken into consideration, and subsidies massively produced. I would just haste to say, Senator Dr. Ifeanyi Okowa brought this concept of social health insurance to Delta State, in fact to the whole country, as the chairman of the health committee, chairman health committee of the Senate when he was a senator. And we went to him and said, oh, for the informal sector, the amount they should pay is, by actuarial calculation, is 12 to 18,000. Then he asked me, Dr. Kwabeta, can you pay 18,000 for yourself, for your wife, and for your 4 children every year? Of course, the answer is no. So he now said something, said, go and look into it again, reduce it, don't worry. The state government is taking a lot of burden off this bill. The hospitals are owned by government, built by government. The salaries of the doctors and health workers is being paid that. Go and give us a figure. And we came out with a figure after initial research of 7,000 for the vulnerable group, for the informal people, just to write their name down, and government will take care of the rest. This is the BAT. This strategy is adopted by Delta State and presently gave BAT what we call Delta State Contributory Health Insurance Commission. We will come back to that full-fledged at the middle part of this lecture. Another strategy being used, next slide, to pull funds into the health sector is private health insurance. Here, individuals purchase health insurance plans from private companies, HMOs they call them. Offer choice and competition, something close to what the MD Khan is trying to propagate about private practice within the government hospitals. Here you must pay a little more, not a little more, a lot of money more before you can be taken care of. But it's a source of funding for the health sector. Can lead to inequities in access and coverage, especially for low-income individuals. They can't pay for this. And that government to bring in social health insurance. Next slide. Community-based health insurance is similar to the social health insurance. People in a given area contribute money like Osusu and help themselves. When one member of the community is sick, they take money from that purse and go and treat them. He hardly survives because someone will get very sick and a huge amount of money will be spent on him, and those who are not really sick, they will start complaining. So encourage community participation and is tailored to local health needs. Challenges, limited risk pooling, financial protection, often requiring external support to become sustainable. If you don't have, there's one in Port Harcourt, River State, but the oil company have to support them for you to survive. Next slide. Another way of pulling funds, which we don't really look at closely, is out of pocket. If you need to see the huge amount people pay out of pocket in hospitals. You know, earlier I was saying that the hospitals we investigated their records, there was a lot of money that they collected, the people paid. And when we added the total together, it was huge. It's huge. And that's a small part of the money the private is paying. Like Dr. Julia said, if not for this, I don't think the hospitals in Delta would have been very comfortable. Because we know government hardly release money even when the law says release that money. So out-of-pocket payments is a huge part. In fact, if not up to 50% of the kind of fund that come into the health sector. But it's very damaging. I've seen people in my village selling only one piece of land belonging to the family to treat one person. So when the next person is sick in the family, what happens? People borrow money, they call you and me every day. My wife is in hospital, I need help. Fonye is my witness. I don't allow him to rest. Cardiac problems. Valentine, I've operated hip surgery for 2 old women for me. One is 110, another one 95 years. And I know how much I paid even when it was kind to me and supportive. And so, out of pocket is a huge challenge. Simple mechanism for payment without administrative burden, agreed, but can lead to catastrophic health expenditures for individuals, driving them into poverty. It's dangerous. We can't allow to continue. Luckily, we are the privileged one, like our colleagues said earlier on, privileged one. But every privileged person has a poor person at home, and you see them every day suffering. Now, next slide. Result-based financing. Financial incentives are provided based on the achievement of predefined health outcomes or outputs. This is not common in our area. This is more when we come to managing the funds, and we're trying to work around it. Require robust measurement and verification systems, which I've put in place, and I will let you know, to ensure accuracy and fairness in disbursement. Next slide. International aid, I also say national, international, and development assistance. The BACPF that we are running in Delta State, part of the fund is from Bill Gates Foundation, Dangote Foundation, the federal government of Nigeria, all put together to source to fund the BSCPF program. So international aid is very, very. In fact, in Rwanda, it formed about 60% of their funding of their health insurance system. Financial resources provided by national, foreign governments and international organizations. You can see what Trump is doing now is cutting back in all this funding they were doing through USAID and other areas because most of the countries are getting weary supporting. So the danger is that can be unpredictable and may lead to dependency. People become relaxed and that, oh, the money will always come from America to help. Often comes with conditions that may not align with national priority. And I find that when these things come, they even tell you what to use to buy. You must buy the vehicle from Ford vehicle from America as your operational vehicle from that money. You must buy the drug from so company. And so the money actually is like giving you the money, the gift from the right hand, a Greek gift, and taking it back from the left. A good country, a smart country, ensure that it minimizes, if you bring the money for you, take it, but be very careful, don't let it be the source and the main source of your funding of your health system. I remember some companies came to us and said they want to train you on diabetes treatment, want to treat you on hypertensive treatment, but you must use your drugs. Abi? So that their company in France can run well if they come with conditions. Next slide. Public-private partnership. Yeah, another good source of funding. Dr. Valentine is proposing something similar to this. And that will bring a lot of money to the system. Really. People are eager to get treatment and go home. Ughelli Central Hospital. My family member will go there as early as 5 o'clock. Before they can see doctor, it's almost midday. Every day I call Omolo. Somebody has been there for 4 hours, and so on and so forth. And only one doctor was available. In fact, there was a day I have to drive in there, and I found the doctor was fatigued, and he had to be lying down in the room, resting. He slept off. He told the patient, I'm coming, let me just, he just went there, and I think he just lay on the couch, and he went and slept off. Because he overstressed, overburdened. And so, if we bring a system in place that will encourage the doctors to work well, more fund will come. But like we said, we must be careful to balance. Already there's this slogan that the government hospitals are being used as private source of practice. If we now legalize it, I don't know how it will work without a backlash on government. Remember that the government doesn't need profit from you. It doesn't ask HMB to declare profit at the end of the year. The profit for government is a smile on the face of the people. And government can even borrow money to keep that smile on the face of people because you need their votes. If the people are unhappy, you are in trouble during election. Even when I know that even when we try as politicians to help, on the election day, they forget the past and tell you today, we must get something. Not talk on when you offended them by not giving them good care. So public-private partnership is a source of funding, strategy for financing the health sector. Leveraging private investment and expertise can enhance efficiency and innovation. Of course, require clear agreements and regulatory framework to ensure public objectives are met. Public objectives is the key, first and foremost. So you don't allow, if you start public-private partnership in the hospitals, we need to manage it with a lot of, and people are very illiterate when it comes to that. So it's a good thing, but it's dangerous to politicians and to the government in power. But we did, in Delta, we have a public-private partnership, specially selected, and I want to announce it here today. When we came in, we follow His Excellency Senator Okowa on campaign. We went to the Riverine area. And Dr. Ben, the former DG, and I were always looking for hospitals in those areas. We saw none. Porobobo, Porozwa, Bimbiri, all that 4 hours boat ride into the high sea. None. And people were living there. And then when we brought all the traditional rulers of the senatorial district, South, to a meeting at Government House to enlighten them about health insurance, one elderly one came, elderly king, and said, please, young doctor, I don't want to die without a doctor treating somebody in my village. The day a doctor can come to my village and treat a patient, I can now die peacefully. Please come and do this for us. And that's how we said we started the Access to Finance program. Access to Finance program was a combination of 3 organizations. Bank of Industry brought money. Pharmacists Foundation of Holland brought money. The government of Delta State brought $500 million into a purse. And it was meant purely for rural, hard-to-reach areas of the state. And we located 25 facilities built by Shell, Chevron, in those localities for a CSR for people. And none of them were functioning. The health centers in the areas, those areas, were not functioning. No doctor want to go and stay in Porozwa, or Igbimbiri, or Sandfield. Because where will she say I'd attend school? And the risk of that area, a lot of kidnapping, when they kidnap somebody in the land area, they take them to those deep areas. So nobody was going. But we enticed doctors to go there. We publish it, and doctors apply from all over the country, from Lagos, from Onitsha, from Ibadan, and we profile them by the Bank of Industry, and we give them a loan of 40 million maximum, 10 million minimum, depending on what you need to activate that facility. There's a facility there, you need to activate it, you need to pay your staff, you need to buy drugs. And 18 took it up. And I'm happy to announce that apart from a lot of people they've treated, we were doing circumcision for men. Because in those areas, when they circumcise the child dies. And they were afraid to circumcise them. So we see a man of 18 years, 19 years, lining up to be circumcised. We took all these pictures. And the United Nations gave us an award for that. And so we did that, and till today they are still running. More interestingly, they've paid the loan. Only one of the hospitals still have a loan about 7 million left. All others who collected money, worth about 400 million, has paid it back, and they are still treating people in those far areas. So public-private partnership is important, and it's very, very important. If you want that loan, and you have a rural area where you can function, activate a hospital, you will see a lot of surgery there. Hemiographies, hydroceles, and all, they come to worry. Most of them, before you get to worry, a lot of them have died. And so if you put a practice there, you'll be surprised the return on investment. And we are ready to give you funds to support that. So this is one of the strategies to pull funds into the health sector. Next slide. Historical perspective. Financing has been a problem worldwide. Very much so. As far back as the 18th, financing is a problem. And because of that, government designed many methods of doing that. So in summary of it, in pro-1900s, out-of-pocket payment, charity, churches, and so were the one. If you remember, even in here, it was churches that were running hospitals for us and so on. And then between 1883, 1940, birth of social health insurance came. Bismarck, Beveridge models came to play. And then 1950 to 70, expansion of public health system and universal health coverage has come in. The concept of universal health coverage, where no one must be left behind, came into being. And of course, by 1990, economic reforms, user fees, community-based insurance, and so others start to come into play. After the COVID, global push for universal health coverage now increased. Innovative and mixed financing models start existing. Of course, 2020 to present date, post-COVID, focus on resilient and equitable health financing, preparation for emergency crises that will occur in health, and so most states are trying to raise funds and provide funds for emergencies. Health insurance is far back. It's a long time. It started in Germany, actually, when they found out that the state could not take care of the workers, and they have to find the workers, bring the workers, lure them to contribute some part of money, and government bring money. In actual fact, government alone can't run health. You need to support government, because the pulse of government is divided into many aspects of the societal needs. Next slide. Now, summary of the key strategies. Effective health financing strategies typically involve a mix of these approaches, tailored solutions to specific national context, and ensure resilience, equity, and quality of health system. No system in the world uses only one. The one I did 1 to 8 is a mixture. Delta is using a mixture of about 3-4 to run the social health insurance we have now. And that's the only way you can tailor it to your needs, because every country has its own health needs, peculiar health needs. Policymakers must carefully design and implement these strategies to address the unique economic, social, and health-related challenges faced by their own population. You must not copy even Lagos State and copy the model in Delta. You must not copy American model and bring it to Nigeria. Yes, the principles are the same, but you can juggle it so that you can have the one that fits your people more. Now, next slide. Strategies adopted by Delta State. Oh, my time is already on? Serious matter. All right, we rush it. Admission of all the above strategies anchored on social health insurance gave birth to the Delta State Contributory Health Insurance Commission. Next slide. A law was created as soon as His Excellency Senator Orhuworun came into power. Before the transition committee was set up, I was mandated to lead a team of 5 doctors to Lagos to meet with WHO on universal health coverage. And for 6 months in Biennial, we put that bill together, and it was one of the first executive bills that was sent to the government. And on the 9th of December 2015, it was passed into law by the House. Next slide. There is in the state established a body to be known as Delta State Contributory Health Commission, in this law referred to as Commission. Next slide. There is hereby established the Delta State Contributory Health Commission governing board that will oversee the general control. The board is a part-time board to see the general control of the commission. Next slide. The board shall comprise of a chairman, the director general, who is also the secretary to the board, and 1 rep from health, Ministry of Health, economic planning, go on, NECA, Labor Congress, TUC, CSO, and of course NHIS. The board of Delta State Law is a unique board in the whole country. It's not political. There's no Delta North. There's no Delta South representation. There's no Isoko, Robo, Anyoma. It is purely representative of organizations and agencies that have a stake in funding, in pooling funds, and protecting those funds. Next slide. The purpose is to regulate, supervise, implement, and ensure effective administration of the scheme. Ensure that every resident of Delta State access good health care. The word is resident, not indigene. Whether you're Hausa, Igbo, Yoruba, Urobo, You are a resident. Once you are a resident, you are covered by the law. Recently, a lot of people have been coming from across the border to assess, and we're trying to control that. Next slide. Receive and investigate complaints of impropriety level against anybody, the enrollee, the hospital, and that's what I touched earlier on. Carry out such other activities necessary to expedient the purpose of achieving the objective of the scheme. Next slide. Now, this is important to the consultants. I will be glad tomorrow, by the time I leave, one of you who is no more a civil servant becomes the Director General. Then, but you must have certain qualifications. You must, Director General shall be a Chief Executive and Chief Accounting Officer and responsible for the day-to-day running of the affairs. Next slide. He has 4 plans: the equity plan, informal plan, formal plan, and a private plan of the scheme. Next slide. I think they messed up my slide, but we'll just go on. Can you go next slide? Go back. Go back. Yes. Apart from the plans, we've introduced some initiatives. The Indigent Enrollee Adoption Initiative, Artisan Enrollee Inducement Initiative, Tertiary Institutions Social Health Insurance Program, and access to finance that I mentioned earlier on. The first one, please, is important, you must know. We realized that the common man was being left behind. The vulnerable were being left behind because they cannot even pay that 7,000. So we made an appeal to prominent people in society, philanthropists, organizations, to adopt and buy insurance for the common vulnerable person indigent in his community. And as today, I'm proud to say that many Deltans have done that. In fact, the PS Health, Dr. Paul Okubo, have just paid for 150 from his community. Is Paul here around? Yes. 150 in his community. And a lot of prominent Deltans have been purchasing health insurance. Actually, we have what we call a landing page. If you just scan, we have a QR code. Once you scan it, it takes you to a point where you can donate and buy insurance for your people. The second one, the word inducement, artisan inducement. The artisans make some money, but they are reluctant to release that money at once. 7,000 looked like a big money to them. But what we did, we took what we call finance line from a commercial bank. It's not a loan. Give it as a loan to the artisans, and they pay 100 naira per day. In 90 days, they've paid the 7,000, and they enjoy insurance, free health care for 1 year. We believe that by the end, and it's already happening, by the end of the year, they should be able to buy for themselves because they will have tasted the beauty of health insurance. And many of them actually are purchasing insurance for themselves at the moment. Of course, the students, we have gotten to them. The student social health insurance had been on by the federal government, but it wasn't working. We rejigged it in Delta State to say that the student, apart from taking care in the health center, in the hospital, in the school, can also take care, health care, when it's on holidays in any hospital that is registered in the scheme, and so on. Ogwachuku just gave us 9,000 Polytechnic. And these are pulling funds into the system, because we are driving on the concept of strategies to bring funds in. Next slide. Financial provision is that a fund was created, and into that fund, money is taken. The initial takeoff grant by government, equity, fund contribution of not less than 0.5% of the revenue of the state. Budget of the state every year, once a budget comes out, use a calculator, 0.5% of that is what must be given to the commission to pay for children under 5, pregnant women, the elderly, and the vulnerable persons in society. To the extent of payment, I will mention that if I have the time. Such other money that come from everywhere. Next slide. From NHIS, we took get some money, like the BSCPF fund, donation and grant from private and philanthropists. We couldn't get that directly, but with this adoption, they are bringing money. They didn't want to give money to us and say, well, we'll give you 1 million or 1 billion. But we now say, okay, use it to buy insurance for people around you, your family members, your neighbor. Politicians are very happy to do that because they know that these same people will vote for them the next election. So, next slide. Now, why DACHC? What are we trying to achieve? The purpose of pooling funds in any society presently now is universal coverage, universal health coverage, whatever way you call it. It's defined as ensuring that all people have access to needed promotive, preventive, curative, and rehabilitative health services of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial hardship. All the grammar, why are you pulling funds? Why is the strategy to pull funds together? It's to achieve universal health coverage. Now, how far has Delta done this? As of today, we have registered 2.6 plus million Deltans into the scheme. And that is almost well over 40% of the population. But before you can say you have achieved universal coverage, you should cover above 80%. We hope to achieve that in the next few years. Next slide. Innovation that we put in place to ensure that people who have registered take good care, are cared for properly, and they are happy to renew their insurance. We have introduced the bundle payment system. Most hospitals, ZMs, we know what I'm talking about here. Facial encounter at point of care, we realize there's a lot of challenges as to who was treated and who was not treated. Was they treated or not? But now it's like OPay account or money point account. You smile onto your phone and then you click your phone and you send it to us in Asaba, waiting for your bill to come. When your bill arrives and the face there is yellow against the black face that is in my computer, the bill is rejected. So facial encounter is an innovation. E-claim submission. Dr. Paul have left. Paul bombarded me in so many meetings. My chairman is here. How can people be coming from Sapele with bill in their hand and travel all the way to Asaba to submit bill with these costly expenses and the danger on the road? You must give us a way that will submit the bill from the office, right from the hospital without traveling. It was a bit high sometimes. I have to appeal to chairman to beg him for me. But it's good. You must have an electric fish, among other fishes, for them to be agile. So that challenge took it, and we're able to bring in e-claim submission system, e-claim processing system. Through this system now, you don't need to come to Asaba. You submit your bill once you set them in properly. Service quality monitors are sent to your facilities to monitor what you are doing. Clear debt determination. I have been able to determine how much we are owing you neatly. I went to the Excellency with the old hospital, 3.6 million. You see, I went second time, He now occurred to me that probably he's thinking. Then he said one day that, are you sure those bills are not ghost bills? So I came back and I prepared your bills, itemized them, and presented the document to him. When he saw that the bills actually were attached to hospitals with date and time, he invited us. Chairman and I went there and said, oh, it's not, I now confirmed they are not ghost bills. Out of the 3.6 billion, I'll give you 1 billion. Spend it and come back. We've spent the money to you, and 1.6 billion has given to us. We spend it every kobo. In fact, I paid 1.62 billion. Instead of 1.6 billion, I added 20 million on top of it, and I paid. Yes. And I've submitted the document to His Excellency. I've submitted the document to His Excellency, and he said we should come back very soon. When necessary return, we'll go and meet him, and then more funds will be released for us. Next slide, next slide, next slide. Yeah, that's the trajectory of our registration. Move on, next slide. And that is it. By April 2025, we have clocked well over 2.5 million, presently 2.6 million. Next slide. We reduce this slide, they can see the end of it, please. Reduce it quickly, quickly, quickly. This is very important. Compress it so that they can see the other end of it. Hello. Remove the zooming. You are zooming in. Don't zoom in. Reduce the zooming. Reduce the zooming. Can you move it to the right? I want to see the left end. No, the other side. The other side. The other side. More. Just a little more, you are there. Reduce the zooming. The zooming is too much. Oh. Please, the purpose of the slides is what I want to see. Reduce that zooming, man. Yeah. So at the end of it, you will see that Delta State is high up there. The next state is Lagos State, far behind in terms of enrollment. And this statistic is from National Health Authority, NHIA brought it. Go back. We have achieved quite a lot. Before I came in, bills were as high as that, but I've crashed it now. Our bills, we can process our bill within a month. Your bill that you sent in. In fact, as you send the bill in, because it's electronic, if you send it correctly, the bill is your bill. If you make small mistake, we correct it and your bill is ready for payment. Next slide. Award given to us by the federal government. This award was handed over to us by the Vice President, Osibanjo, for being the best health insurance. Yes, thank you. And we made Kowa proud because he worked very hard for this scheme to be around. Next slide. This is another award that was given to us. This one was a voting award. The vote was voted across the whole country, and we came far the best. And the award is sent it to His Excellency to come and receive the award, but he said we should represent him. The MD of LUT and the MD of UCH are the one that organized this award process. Next slide. Thank you very much.
Hello. Please, let's once again give our speaker a round of applause for that very, beautiful presentation. Thank you very much, sir. Thank you, sir. And once again, I want to also appreciate Mama for her team lecture, Dr. Mrs. Julia Caroline. Thank you once again, ma. God bless you. Please, there's something we just want to do right now. Dr. Amina, please. Can I have those? Yeah, thank you very much. Dr. Mitajuya, please, I would like you to please maybe step forward a little bit. Thank you very much. Thank you, ma. Thank you. Thank you, ma. Please come. I would like Dr. Ofunye to please accompany our mama. Thank you. Thank you very much. Thank you, ma. Thank you. Dr. Mamodo, please, can I have those plaques very quickly? Thank you. Very quickly, please. Let me fast over that. Thank you very much. Thank you very much. So, ma, I want to say thank you very much on behalf of MD Khan. We have decided to present this to you. So, permit to read what is here. Medical and Dental Consultant Association of Nigeria Hospital Management Board, MD Khan HMB Delta State, with our greatest appreciation. Okay. Thank you. Okay. Okay. All right. So, as the team speaker of our Biennial General Meeting and Scientific Conference 2025, we are grateful for the well-delivered lecture on effective healthcare delivery in Delta State, past, present, and future. This day, 25th of July, 2025. Courtesy 2023-25 ESCO, led by Dr. Philemon Okole. So please, Dr. Orhuworun, you help us hand over this thing to our mama on behalf of MD and HMB. Thank you, sir.
Thank you very much. On behalf of MD Khan, members and executive, I hand over this plaque to you for all your good work and for this service that you've done us. Thank you.
I appreciate. I love you all. Thank you very much.
Thank you very much.